Most people think RSI is just push drugs and intubate, but real airway management is controlled physiology. The drugs you choose before intubation can stabilize the patient or crash them within minutes. Rapid sequence intubation has two major drug components, the induction agent and the paralytic. The induction agent sedates the patient and induces unconsciousness. The paralytic removes muscle tone and vocal cord resistance to facilitate intubation. But here's the critical part. Every RSI drug changes physiology differently. There is no universally best induction agent. The correct drug depends entirely on the hemodynamic state of the patient in front of you. Etomidate is often chosen in unstable or hypotensive patients because it is relatively hemodynamically neutral. Typical dose is 0.2 to 0.3 milligrams per kg IV push. It provides rapid unconsciousness with minimal cardiovascular collapse. But remember, etomidate is not an analgesic. Ketamine is extremely valuable in critically ill patients because it provides sedation, analgesia, and usually preserves airway reflexes and sympathetic tone. Typical RSI dose is 1 to 2 mg per kg IV. In shock states, ketamine often supports blood pressure through catecholamine release. But in catecholamine depleted patients, prolonged septic shock, ketamine may unexpectedly worsen hypertension because the myocardium can no longer respond adequately. Propofol is excellent in controlled elective airways because it provides deep sedation and reduces cerebral metabolic demand. But in unstable ICU patients, propofol can cause profound vasodilation and myocardial depression. Dose is usually 1 to 2 mg per kg IV, but critically ill patients often require much lower doses. A septic patient who is compensating with massive sympathetic drive may arrest if you remove the compensation too aggressively with propofol. Midazolam is slower and less predictable for RSI compared to other agents. It may be useful in selected scenarios, but in general, it is generally not the ideal primary induction drug in crashing airways. After induction comes paralysis. Succinylcholine is a depolarizing paralytic with extremely rapid onset and short duration. Dose is 1 to 1.5 mg per kg IV. It works by persistently depolarizing the neuromuscular junction until paralysis occurs. The advantage is speed. The danger is potassium release. In hyperkalemia burns, prolonged immobilization, neuromuscular disease, or crash injury, succinylcholine can trigger fatal arrhythmias. Ricuronium is a non-depolarizing paralytic. Typical RSI dose is 1.2 mg per kg IV for rapid onset. It avoids the potassium risks of succinylcholine and is increasingly preferred in emergency airways. But its paralysis lasts much longer.